Good morning and welcome to our first LifeFlow Ask Me Anything meeting. I'm Liz Groover. I'm going to be moderating today. I'm going to start today by introducing our experts, our speakers for the day. I'm going to start with Leslie Fowler. Leslie, will you raise your hand?
Hi.
Good morning. Thank you for joining us. Leslie is the Trauma Program Coordinator at North Bay Health in Fairfield, California, where they are currently using LifeFlow in the ED for trauma and the delivery of blood. Beth Bolton. Beth, would you raise your hand? Beth Bolton joins us. She's a PICU nurse and one of our LifeFlow clinical educators. She has extensive experience with the LifeFlow and can answer any of the questions you might have about usage, troubleshooting, anything like that. And we're also joined by Dr. Mark Piehl. Probably no introduction necessary. He's the pediatric intensivist at WakeMed and chief medical officer of 410 Medical and the inventor of the LifeFlow device. Thank you all for joining us today. I'm going to get started with the first question that came to us through the registration form, and I'm going to give this question to Leslie. The question is, in pediatric massive transfusion, number one, how should we be using the LifeFlow? And number two, how does it compare to the level 1 or the Belmont? Leslie?
So for us, since we got the LifeFlow, the instruction is anytime we have pediatric trauma, we're going to go directly to the LifeFlow. We're going to bypass the Belmont altogether. They should be using either a correct rate as soon as the patient arrives, or use the Broslow tape to see how much the patient should weigh, so we can correctly give the amount of fluids that the patient needs. The LifeFlow is excellent because each squeeze is 10 ml, so you can accurately give the amount of resuscitation fluid or blood that the patient needs. So we are decreasing the risk of overfluiding the pediatric patient. We don't want to do a greater risk. We want to benefit the patient, and overfluiding the patient is not going to be good for resuscitation.
You mind if I add on to that, Liz?
Go right ahead.
It's an interesting question, and the whole concept of massive transfusion, I think, is sometimes confusing because the definitions vary, and we don't always know when a patient arrives that they will need a massive transfusion by whatever definition you use. In adults, it's something around 10 units of products in the first 24 hours. In kids, a definition might be 40 mils per kilo of blood products. And I think what's essential is that someone who comes in shock needs, particularly with trauma, needs blood immediately. And they may or may not progress to needing a true massive transfusion. We may activate the protocol so that all the products are there, so that the cryo and the FFP and the blood and the platelets come down from the blood bank in a timely way. But the patients who need something quickly, so an adult with traumatic hemorrhagic shock or a child with trauma and hypotension, need an initial amount quickly. So that may be a unit or two in an adult, and maybe 20 to 40 per kilo in a kid to start. But that then may or may not progress on to a massive transfusion, just for clarification of that term. And I know that everyone's definition and understanding of that varies, but I think the key is the right amount for the patient to reverse their shock early.
You use the Belmont as well. You have the Belmont. How do you find the LifeFlow compares to the Belmont?
So for the Belmont, it infuses so fast that you can't control it as good as you could with the LifeFlow. The LifeFlow, you're handling by yourself. You can count as much as you're giving. For us, the LifeFlow is an easy way to control the amount that we're giving. It still goes in super fast. You can control everything about it. If we're going, the 1-to-1 on transfusion, we can pull stuff off, because a lot of times they're not going to get that full unit of blood, especially for real little ones. So they don't need all that essentially. So it's easier to control what we're giving, when we're giving it. The doctors can tell you what we're doing, and we can just easily pull it off and add on and start and continue with what we're doing.
So, Dr. Piehl, in follow-up to that first question, which is when should you use the LifeFlow for massive transfusion, when should people be using the LifeFlow in sepsis?
Right. So I would say the first indication is shock, and sepsis is one of the most common forms of shock. So septic shock is usually a systemic infection with end organ hypoperfusion, meaning there's not enough, something has deranged the working of the cardiovascular system so that not enough blood and oxygen is getting to the tissues. And we often recognize that in adults by tachycardia, low end tidal CO2, altered mental status, and in its extreme form, decompensated shock, which is hypotension. So I think, and we know that there's evidence that the earlier we treat shock, whatever the form is, hemorrhagic, septic shock, anaphylactic shock, the better the patient will do. The quicker we reverse that, achieve some stability, the better the patient will do. And the faster we then progress on to other interventions. And in some cases, we may not need to do other interventions like intubation, for example. So we've seen in a lot of our research, both in sepsis and in trauma, that patients who have their shock reversed early with, let's say, 2 units of blood or a liter of fluid, who initially look like, wow, I've got to intubate that patient, may actually perk up and not need advanced airway management. So I think, I guess my principle would be when someone comes in with signs of severe shock, that we would want to immediately think about treating that with the appropriate type of fluid. In sepsis, normal saline, possibly LR. In trauma, ideally whole blood or blood products if we have them.
I see that we have a question from Dr. Phipps, who's interested in understanding how widely adopted LifeFlow is. Dr. Piehl, do you want to answer that one?
Sure, and I may invite Christine or someone else in as well. So, John, good question. I think we are now in over 200 hospitals and EMS systems. And Chris, you can nod if I'm right about that, or they're more, probably more than that now, close to 250. And I would say, John, that the use cases vary by hospital system and EMS agency. A lot of places are using LifeFlow primarily for trauma resuscitation or hemorrhagic shock, and others primarily for fluid resuscitation and septic shock anaphylaxis. Interestingly, right where you're sitting, I believe you're near Alexandria, their EMS agency is purely using for septic shock resuscitation, whereas neighboring EMS agencies that bring patients to your hospital may be using it for blood, like in Loudoun and then in the southern part of Virginia. So use cases vary. Some hospitals like my own and others in North Carolina and some in Florida and Louisiana have kind of adopted for global uses. So kids, adults, blood, fluid, kind of that idea that early resuscitation is key, whatever the age and indication. But it's getting out there more and more, thankfully. Also didn't mention a number of air medical agencies, so helicopter use is becoming more common as well.
Can I ask a follow-up question?
Please,
my hand,
please
Liz?
do.
I'll raise my hand. I'll put it right in this.
Right ahead.
So what feedback are you getting? Is anyone saying we tried it and we prefer to use something else, and if so, why?
Yeah. Chris, why don't you take that one?
Oh, thanks, Mark. So John, good question. I think for the most part, we have a success rate about 95% of people that evaluate LifeFlow will go on and implement it.
Leslie, how have you viewed that in your own ED? Kind of the success of adoption after a trial?
Yeah, for us, we've used the Belmont as our primary. So with trauma resuscitation, a lot of our patients that need the blood or they don't have peripheral IVs is IO. So the Belmont really fills on the IO resuscitation part, where the LifeFlow infuses perfectly, super fast, goes in. I don't have to worry about the Belmont failing with the IO, and we have failed a patient resuscitation. So they know now, for like, my direction is anybody that comes in with an IO, they don't even set up the Belmont anymore. We pull the LifeFlow out, so that way we know we're not going to fail the resuscitation part with fluid or blood, whatever we need to do for this patient. I haven't gotten into the sepsis part. That's going to be my next step. I just got a new educator. I really want to push this for sepsis also. I just haven't had the educator to help push this along with my upper management. But for trauma, we got it specifically because we have the Q and Flow also, which is our warmer that attaches to the LifeFlow. So it's fantastic. if you need to go and rapid fluid, if they have to go straight to OR or if they go to CT, it follows with it all the way through. So the resuscitation continues, whatever which part you're going to go through within the ED.
Thanks.
We
Yeah.
love it.
I see
Thanks.
Beth has a hand up, and John, I have another thought for you, but Beth, what was your question?
It's not a question. It's just speaking towards the adults and the feedback that we get whenever we go to adult EDs. A lot of the pushback that we get, especially with seasoned nurses, they're so used to grabbing the pressure bag and they think that, oh, I can just squeeze and get the pressure up on the pressure bag and just walk away and keep doing things. But it loses its pressure so quickly that you're not actually giving it at the rate that you want to give it. And if you're not doing that, it's going to go over 30 minutes versus the 4 minutes we can get the leader in with the LifeFlow.
Just one more thing to add to that. I have seen with adult hospitals, especially like level 1 trauma centers, that they will always grab the Belmont of level 1. I mean, it's their go-to. I never bash other products. I think Belmont's better, but I do think you can get the fluids in very quickly and it's warmed. I always put it like, this is a bridge. You can get this set up in under a minute. You can put it on your patient and get a unit of blood in or 500 milliliters of fluid in less than 2 minutes. And when we talk about that with these clinicians out there, the next question I always ask is, what do you use for sepsis? Because I've not yet had one person say they use the Belmont level 1 with sepsis. So every septic patient is either on a pump or it's on a pressure bag, which is too slow. So I think a lot of these adult hospitals are now changing and getting LifeFlow in with their sepsis carts, their shock carts and stuff like that.
John, obviously we're biased, but I think the general idea, particularly for septic shock, is what we do now is good enough. And if it's slow, it's just the cost of doing business, and
Right.
Why do I need to? And I think we can share plenty of data, both that are published already independent of LifeFlow and increasingly with our own hospitals where we're studying it to say, wait a minute, actually earlier fluid, and it doesn't have to be their full 30 per kilo, but their first 10 or 20 to get their hypotension reversed and begin that resuscitation quickly actually is making an outcomes difference in terms of lives, interventions, and maybe even cost. I can't prove that yet, but probably cost.
A lot of them have just been answered as we go along. Maybe the role of a LifeFlow with a fluid challenge might be one, or the risk of giving cold blood. Those were a couple that came up that I thought maybe we could answer in these last couple minutes.
Yep, quickly. We've given cold blood to patients for years and shouldn't have. I've done that since I was a young doctor. And it's probably true that in someone with hemorrhagic shock, the first unit or 2 cold does not do harm. What does harm is 20 units of cold products in the OR during surgery, which results in systemic hypothermia and coagulopathy, and that's bad. But ideally, everything for a trauma patient we give would be warmed. We now do have a partnership with a company whose warmer is compatible with LifeFlow. Most of our customers, John, for you to know, use that warmer called the Warrior, Q&Flow Warrior, whether it's in ED like Leslie or in EMS. And so I recommend that if we're going to give blood to a trauma patient or a GI bleeding patient or a woman with hemorrhagic shock after delivery, that we give it warm if possible. It probably is better and it feels better. We know from patients that are semi-awake, when they get their blood warm, they like it. When they get it cold, they don't really, even though it makes them better. So that's one. What was the other question?
The fluid challenge.
Oh yeah. So back to John's point in terms of adoption, one of the fears in the ER, particularly of the docs, may be, I don't know that this patient is going to benefit or have harm from fluid. So I want to do a fluid challenge. The concept of fluid challenge really comes from the ICU world where I live, where someone's already been pre-resuscitated and then they're hypotensive and I got to decide, am I going to give fluid? Am I going to give epinephrine? What am I going to do next? And so a fluid challenge, a small dose with some type of objective response, whether it's a cheetah monitor or some other type of cardiac output monitor, an ultrasound, is a nice way of determining, did that fluid make a difference? Those technologies tend to be complex, and if you give the fluid slow, you really have no idea if it mattered. And so LifeFlow actually allows someone at the bedside to give that challenge of 250, for example, or 500 in an adult in a minute. And everyone can stand there and say, wait, the perfusion's better, the pressure came up, the heart rate went down. That was effective. Or I can look at measures of cardiac output with ultrasound, which are more complex, which we often do. But the LifeFlow does allow you to immediately do a dose and response. And as Leslie was saying, not overdo it in a kid or an adult. I can give the right amount. They're better now. Their heart rate's better. The end tidal's coming up. The blood pressure's better. I can stop. And so something that requires that I infuse it by hand and then stop allows me to titrate the therapy. And I'm actually thinking of actually one of Beth's cases where she had to give blood quickly to a trauma patient up in the ICU who was bleeding, and knew by the response that patient showed when we've given enough, and now we can go to the OR safely. So that's one of the benefits for sure. Fluid or blood. And I see Leslie nodding her head as if that's what I'm saying is probably true. So good. Thank you.
Thank you very much, and have a nice rest of the day. Bye, everyone.
Thanks for hosting us. Bye.